Hi, everyone. I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions every 2 to 3 weeks, along with the Ontario College of Family Physicians. And I'm going to turn it over to the OCFP President, Liz McGaugh, to introduce the session. Liz.
Thanks so much, Tara. So welcome, everyone. So happy to be gathering today again together as a community of family docs from right across the province. We have a terrific panel for you. They will introduce themselves shortly. Just a reminder that this is a Main Pro accredited session and you'll get information about that. Next slide. I'm going to read the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I am calling in from unceded Algonquin and Anishinaabe territory. Next slide. And just wanted to highlight, we all know, of course, there is an election coming up and important to understand and be aware of what the issues are that are facing our Indigenous communities. So I was pleased to see that the Chiefs of Ontario hosted an all candidates meeting. It was in the end of April and identified here what their key priorities were. Not surprising to those of us on the call, I would think, but housing, mental health and addictions, and importantly, community-based services. So not only the issue around making sure services are in the community, but extending that into opportunities for self-determination of healthcare for our Indigenous populations. Next slide. And I think I'll hand it back to you, Tara.
Thanks, Liz. So as you know, these are a series of sessions that we're offering, and all of our past sessions are available on our website. Today's session, the recording will be up later today, along with the slide deck, and the Q&A, a summary of the Q&A will be there a few days later. This session is going to build on past sessions. So our last session was focused on Paxlovid. We had a terrific session really going into the details of prescribing, some of the contraindications, but also importantly, how you approach this disconnect between what the Ontario Science Table has recommended and what the eligibility criteria are, and how do you as a physician navigate that. So we had a great discussion last time. We aren't going to repeat that discussion today, but build on it and continue to enhance that discussion around our role and answer any more questions you have. Next slide. So I'm delighted that we have this great group of folks to help us talk about Paxlovid and what else is new in COVID. Next slide. And of course, our co-hosts who continue to join us. Next slide. And so I'm going to turn it over to our panelists one at a time to introduce themselves. I'm going to start with Kim.
Hi, everyone. I'm Dr. Kim McIntosh. I'm a family physician in Orillia. I am, like all of you, I'm a busy family doc. I have a practice of 1,800 patients. I share office overhead with 6 brilliant office mates. I happen to work in a FO, in a family health team, and in a first wave approved OHT. I am program medical director at Soldiers Memorial Hospital. I have privileges there and look after patients there as well as my comprehensive community practice. And I'm the Couchiching Ontario Health Team physician lead. And I just sort of stayed in the seat of sub-region lead and transitioned to OHT lead. Having said all of that, I'm really excited to bring you some examples of relationship building that has made Paxlovid prescribing supported in our community and in ways that many of you can probably, respond to and understand and feel has supported you in your communities as well. Really glad to be here. Thank you.
Thanks, Kim. Kristen?
Hi, good morning. Thanks for having me. My name is Kristen Watt. I'm a community pharmacist. I practice in Southampton, Ontario. I am the owner of a small independent community pharmacy. I have specialties in palliative care and pain and have taken a great interest in COVID vaccines, testing, and treatments. I also contribute to Focus COVID Communications. You'll see one of our documents later in this presentation. I do receive money from various sources, including honoraria to speak today. way, but I don't believe that I have a conflict of interest in what I will share with you today.
Thanks, Kristen. Zane.
Hi, everyone. I'm Zane Shagla. I'm an infectious disease physician based out of St. Joe's in Hamilton. I've been working significantly with COVID therapeutics for the last 6 months, which has been probably the biggest part of my practice. And in terms of conflicts of interest, other than being here today, I will be talking probably about therapeutics at some point during this conversation and Evusheld. So there are COIs with AstraZeneca and Gilead, as well as a research grant from Gilead for some long COVID work.
Thanks, Zane. David?
Sorry, there's something causing me to sneeze in my office today. Thought I had another one coming on. I'm David Kaplan. I'm a family doctor in North Toronto and the Vice President Quality at Ontario Health. I receive an honoraria from the OCFP for these sessions, and I receive salary support from Ontario Health.
Liz.
Good morning, Liz Maga. I'm a family doctor in Ottawa, and as I mentioned, president of the Ontario College of Family Physicians, and I receive a stipend for that role, but I have no conflicts to declare for this session.
Yeah, so I introduced myself as Tara Kieran, and you can see here that I have been lucky to get some grants, research salary support, as well as honoraria. I don't think any of them pose a conflict for today's talk. Next slide. So today we're going to start off by hearing from Kim, who, by the way, I think was one of our first ever panelists in our community of practice session 2 years ago. Hard to think back that far. We're then going to move to hearing, how Kristen is managing Paxlovid prescribing in her pharmacy, and kind of tips for us as family doctors for how we can enhance that collaboration. And then we're going to hear from Zane, who really is going to have a potpourri of good stuff for us. I think when we looked at your questions that were coming in at registration, they were in a variety of topics, and he's going to just give us the latest on COVID in Ontario, variants, vaccines, and then prevention. So we're going to talk then about Evusheld. David's going to jump in there about the Ontario Health, the Ontario plan. And we'll talk about boosters and where, what the gaps are and what's still remaining. And of course, we'll make lots of time for your Q&A. So just an update on where we're going to go today over the next little while, and a reminder that today's session goes until 9:15. So I think all of you know this, but put your questions in the Q&A box. Don't put them in the chat because it's hard for us to keep track of that. And then we definitely prioritize the questions that get the most thumbs up. So don't repeat someone's question, just gives it a thumbs up if you like it. And I'll get to orally all of the questions that have the most thumbs up, and we'll try and answer as many questions as possible also through writing. Of course, we love to get your comments, your feedback, your reactions, and resources in the chat. So use that to network with others. Next slide. So without further ado, I'm going to turn it over to you, Kim. Next slide.
Thanks, Tara. And thanks for having me. I can honestly not quite remember 2 years ago. I do remember attending. I'm not sure what I had to say then. What I have to offer this amazing group of over 500 participants today is probably a story that sounds very similar to your own. And it's really a story about trusted partners working together, and some of the learnings from pandemic, particularly around Paxlovid prescribing, that highlights how instrumental family docs are in their teams, in their communities, to improve access to assessments for COVID-related disease and in Paxlovid prescribing. Next slide, please. Why am I here? I want to give a shout out to all of you. I want to show how many of our OHT relationships have been galvanized in pandemic response. And I want to really highlight that I know I'm in a team, I'm well supported, but many of these examples are external to a formal team, and many of you have created relationships. If you haven't, consider making a phone call, befriend a pharmacist. So much of this is about relationships and communicating and peer support. And we're more homogeneous than we realize in primary care across the province because of our relationships, our intention to build primary care home, and also to account for provider satisfaction when we're all really pretty stretched. And how do we do that and look after our patients? It's in a context of a team-based approach. So that really is the backdrop to how I can get to Paxlovid prescribing. Next slide, please. So our population in Couchiching is 85,000 attributable population, which you may say is small if you're in an urban setting and a solo doc in an urban setting, but this is a scalable approach. And again, I think all of the speakers today will highlight relationships in this context. And I really want to shout out to our regional and provincial tables that have evolved over pandemic to let us cross-pollinate how we can approach COVID assessing, treating, vaccinating, et cetera. Next slide, please. So in our organizational structure, and again, this is all backdrop, there's some key points. Our primary care council has created a network for our primary care providers across the board, so all of us can assess and prescribe. Our congregate working group had retirement homes, all 9, 2 years ago, connecting with family docs, with pharmacy, and those pharmacists came forth, community pharmacies, 2 years ago to provide flu vaccine in the context of they weren't necessarily the connected pharmacy to that retirement home, but they came and they provided flu shots in-house. They were our partners throughout. So pharmacy came to the table. Our social determinants of health working group created a place to recruit providers to a new medical center at our shelter. I mean, these things happened in a time of pandemic, and I just can't highlight enough these tables and the partnerships that have evolved and that have led us to our ability in Couchiching in particular to ensure access for even our most vulnerable. Next slide, please. So we're all familiar with needing to test for COVID and all the different permutations, eligibility criteria, the need to vaccinate. We all jumped on board. We have, we spent a lot of months sorting out COVAX enabling providers. We had a primary care response table where providers met to stick handle 1 after hours clinic or 2. Are we going to assess over here or over there? Who has enough PPE? So just setting the stage. Next slide, please. So our stats at a glance. So there's the qualitative, the quantitative, and our stats here are for our Couchiching Ontario Health Team testing, assessing, and treating. And I want to highlight our COVID at home service, which is ProRes. So an oxygen company came to the table. They're one of our anchor partners in our OHT and said, we can do 7-day-a-week assessing. Just use our usual referral form, right? COVID assessment, and we'll call the doc or the NP and we'll review the oxygen saturation, the patient's vital signs. We've had clinical assessments to the tune of over 6,000. That's across all of our provider sites. And then there's Paxlovid. So 63 scripts have gone out. Paxlovid was the kind of the last layer of our COVID assessing, vaccinating, testing strategy. And it's less about 63 prescriptions and more about assessments and how do we get people to the right place and to be able to assess them in a timely way and prescribe when appropriate. Next slide, please. So this is so instead of a COVID assessment center, or a cough, cold, flu clinic, which is over here. We met as a primary care group early on 2 years ago and started saying, are we going to collect our services? Are we going to distribute our services? How is this going to work best to meet all the demands of our patient population? Because there are needs other than COVID in our primary care comprehensive way, as we all know. And Aurelia Soldiers Memorial Hospital has been an instrumental partner. Thank goodness for a engaged, integrated hospital partner. Got to have one of those. So OSMH has provided the testing 7 days a week with an RN, RPN, and I've been the medical director. We've huddled for 2 years to talk about communication sheets, medical directives. They get the results. So PCR and RAT testing 7 days a week in one place. And then that coordinator, navigator, nurse is assessing, whether it's on the phone or in person, and they are calling the provider. They're calling that family doc, or they're calling the NP that our OHT hired to look after vulnerable, or they're calling the medical provider at the shelter, or they're calling the NP at our Mum Away with Dodoko Indigenous provider or our NP clinic. So we created a pick up the phone and call to ensure that there was testing and an entry point for all comers that kept up with all eligibility criteria, warm handoff to patient and provider. And that RN or RPN from our OSMH testing center was kept up to, we kept meeting together to ensure they had the latest information. They reflected back to the health unit, of course, at regular intervals to ensure they had the right information. They participated when it was required in contact tracing if the health unit was challenged in that regard. So we had this really amazing, and we revisited this model regularly to ensure access. RN, RPN could refer to COVID at home. Any of us could refer to our community paramedicine program that predates COVID. So we were feeling pretty solid about testing, assessing, and then treatment landed. So OSMH was approved as one of 15 Paxlovid distribution sites. Great, yay. So OSMH leadership and myself, we and our pharmacy, OSMH pharmacy, met. OSMH is not an outpatient pharmacy. This is an outpatient therapy. So harken back to my retirement home table and the pharmacists who were there, community pharmacies, and I made a phone call, and lo and behold, a local Shoppers pharmacist owner, brilliant, amazing, already engaged with us through 2 years with our OHT pandemic response, says, sure, we can distribute Paxlovid. So we all meet together. I say, great, okay, Paxlovid is in this pharmacy. Now we need the patients who are being assessed by all these providers to receive a prescription. How do these providers, so there are 26 provider sites, 22 family doctors' offices, solo practice, faux offices, all different permutations, combinations, like all of our communities. Okay, now what? How do we support those prescribers? So that was my work for a weekend. Next slide. Because again, I'm in practice, I'm busy, I need a way to, if I'm going to prescribe. And the nice thing is about all this planning, I may be busy, but every time I plan and create relationships, it makes my practice better served. It makes my job easier in essence, because I know I have a trusted team and I have resources. So I used the science table and the University of Waterloo pharmacy sheet, and I added it to this form. And I borrowed a few hours from our IT with the FIT, brilliant woman. She can make forms when I can't. Gave her the information and created a communication tool that the prescriber would use and send with the prescription for Paxlovid to the pharmacy. The pharmacists at our dedicated pharmacy in the initial rollout were involved with this form. So we had some meetings, we reviewed it, and then the IT, Family Health Team IT person put it in as a custom form in our practice solutions and our EMR, and our FO manager got it out to all the different, and our EA for our OHT got it out to the individual offices. So this is embedded in our EMR right from the get-go, right from the first days of Paxlovid prescribing. And I sent a lot of emails and communication to support. It pulls the height and weight, pulls the creatinine, reminds you, cues the clinician about all the drug-drug interactions, and then it goes to the pharmacist to make their job easier with the prescriber's cell number on it. So there is an ask for that. I had to revise it once to account for the increased eligibility criteria. And when the province came out with expanded criteria, I added a statement that is prescriber discretion. So as we all do with all drugs all the time in primary care, we have a conversation, informed consent, limitations of the data. And I added that for prescribers to feel, that they had the abilities to make a decision with the patient and with the pharmacist about treatment with Paxlovid. And this form we've also circulated through Simcoe Muskoka at our regional meetings to try to support primary care in prescribing Paxlovid and the pharmacist and prescribers to connect on this new and challenging activity. Next slide, please. So here's a quick story, patient story and a provider story, because this is as much about provider satisfaction and support as it is about the patient's journey, right? We've got a quadruple aim to account for. So this was a gentleman who presented to the emergency department at Soldiers, smoker, unvaccinated, been unwell for about a day, unwell enough to want to seek care, but he wasn't certain he really wanted to be in an emergency room or in a hospital. Unvaccinated, lives remotely, doesn't have a family doctor, and the emerge doc is a bit uncomfortable. He didn't sat well when he's up moving around. And again, he refused to test for COVID, finally consented. Yes, he's COVID positive and he's moving around the department. All those challenges that we know we have with disease transmission. And the emerge doc calls the hospitalist. Happens to be me in this case, but it could be, I was on that week, could be any of my colleagues. So the emerge doc wasn't aware of some of the, even though when we communicate a ton in emails, not everyone hears the info, no problem. Emerge doc says, I'm going to admit this gentleman. But boy, oh boy, he's a handful. He doesn't really want to be here. I'm like, well, can we meet his needs and provide care at home? So I reassured the emerge doc that I would follow up. I made sure the creatinine was drawn. I said, hey, send a ProRes referral. Just grab the sheet. It's in the department. And the COVID at home program, ProRes will send an RT to his home. Please fax me all his demographics and a phone number that works so I can get a hold of him. And that all transpired. The patient left the department. Next slide, please. So Sunday morning, I've done my hospital rounds. Sunday morning, before I get rolling, I get a cell call from the RT, respiratory therapist. He's doing fine, sounding okay. He's 3 days from symptom onset. It's Sunday. Our community pharmacy is not open on Sunday. That's okay. I've got 5 days. He's stable. So I call the patient. I introduce myself. I have a discussion. I get his med list as best I can. I talk about Paxlovid. And then I consent to call his daughter, because I need to know his cognitive status. I talk to his daughter. Is he making his own decisions? How are things going? So I consent and I get some additional information. The daughter understands the process, says, yep, dad makes his own decisions. He can be a bit of a grumpy Gus and a bit of a tough fellow, but it sounds like, you know, if he's agreeing to a Paxlovid treatment course, that sounds reasonable. So that worked well. So first thing Monday morning, I'm heading into my office anyway. And at 8 a.m., I'm into the office. Doesn't start till 9:30. I hand my receptionist demographics. She makes a quick chart in Practice Solutions. I go in my EMR. I pull up my custom form. And yes, there is an insertable version of the custom form for Practice Solutions. And I OLIS his creatinine that I know the emerge doctor on Saturday, yay OLIS, and complete the form. I call the pharmacy just to make sure about delivery, because he lives remotely. He's out in the boonies. And they say, sure, we can arrange delivery. And I call the patient again, and things get rolling. And a few days, I gave him a couple of quick more phone calls, and he responded to therapy and carried on with his life. And next slide, please. So moral of the story is that was a lot of touch points, and how amazing that that entire team and the patient's family were engaged and involved. And it didn't take a ton of time for me, but it used my skill set in the right way as a provider, as a physician, along with the pharmacist, the emerge doc, the delivery person, my receptionist, the patient, and the patient's daughter. So I truly believe that, you know, Paxlovid, that example, highlights that we can have improved provider experience and improved patient experience. He didn't want to be in hospital. Admission avoidance. Yay. Also a strategy, right? If folks don't need to be in hospital, let's not have them there. And this is relationship building and resource sharing, and we work full scope and we share the load. So some highlights: burnout can be mitigated by meaningful investment in your team, and it can be an informal circle of fellow providers, of peers, of friend pharmacist. And I will see Tara's hand up and finish off. Thank you so much. Next slide, please. So lots of thanks to all the folks who provide information on a regular basis, and some future thoughts.
Thanks so much, Kim.
Thank you.
I know it's hard to summarize like the amazing work that you've been doing over the last 2 years in leading in a rural community and doing so well. I think you really highlighted the role of collaboration, and I love how there's no wrong turn, no wrong door, and you're really trying to make it accessible for many people from different backgrounds. So thank you for highlighting that. I'm going to turn it over now to Kristen to give us a different perspective, the perspective of the pharmacist. We know that we've all been communicating much more with pharmacists because of Paxlovid, and it's something that we should be doing all the time, regardless of Paxlovid. But I love, Kristen, I'm going to turn it over to you because I know you have a few pearls for us, and I know I've learned from you about what you're doing in your pharmacy, and has helped me to think through our own practices in our office.
Excellent, thank you. Can you hear me okay?
Yeah.
Fantastic. So I own a small independent community pharmacy in rural Ontario. So I'm in Southampton, Ontario, which is part of Saugeen Shores in the Grey Bruce region. When Paxlovid was being rolled out to community pharmacies, I was already doing some conversations at a higher level with OHT about how we were going to roll this out in our location. And then all of a sudden it was announced that it would be in every community pharmacy that wanted it immediately. So what I did was I sent a message to all the local physicians outlining what our plan was. I'm really lucky that I have that contact information for so many of them, and then I know it gets disseminated out. So I'm very fortunate to actually practice in a rural area. I know we talk about access all the time in rural areas, but this is one way that patients have improved access because we talk a lot. The payment model for pharmacies to dispense Paxlovid really pushed the responsibility of managing Paxlovid onto the prescriber, because it didn't come with very much money to allow us to do what we need to do for safety. So what I decided to do in my location was to start by using the meds check program, which I know every family doctor on this call probably hates because you get those terrible faxes from all of us. But I actually leveraged using that money that we get from billing those meds checks to give me the time and the staff needed to do those medication reviews. Because I think at the bottom of the prescription for Paxlovid, at least the ministry one or the OMA one, it says the prescriber is responsible for all follow-up. But when working with our location, we're doing a lot of the follow-up for the family physicians and for the patients as well. So if we can go to the next slide, there are essentially 3 scenarios that we've seen in our location. So I think I put on the previous slide that we've done thousands of COVID vaccines, thousands of tests, and we're at about 10 prescriptions for Paxlovid so far. So the first scenario that we see is a prescription coming in. And I actually have a patient where this happened. They weren't my patient. This was a transient patient who was underhoused, not fully vaccinated, and the prescriber was an NP helping out with a rooming house who didn't know all of this patient's history. We queried opioid use disorder, something that's a big red flag in our patients who may be underhoused that we can't use Paxlovid in. The catch with this patient is they had a DVT 2 weeks ago. They were on apixaban. Based on the management guidelines, they should have been receiving a low molecular weight heparin if we were going to put them on Paxlovid, but this patient wasn't interested or willing to inject themselves. We didn't have community paramedicine that could go out and inject them. It took 4 different people involved in this piece of management. I was in contact with a Pharmacist, with the phenomenal Menica Pai, and also the hospital pharmacist. And finally, we came up with a plan for this patient. But it was great because the nurse practitioner who was prescribing it knew that I've been doing some Paxlovid work and she could call me and we could manage it. This patient wasn't my patient, but we got all the necessary information that we needed and the medication was dispensed. Go to the next slide. Another scenario that we've seen is a preemptive prescription arrives because there's a family med visit where the patient's identified as potentially being a patient who would benefit from Paxlovid, and the script gets sent to us. This one is great because we have an internal process in our pharmacy, whereas once the prescription is received, the patient is contacted and they are booked for a medication review. When it's preemptive, it's fantastic. It took me about a week to get to this patient because we're so busy otherwise. And I was able to sit down with the patient to talk about the indications for their medications to understand where we might be able to avoid some drug interactions. So this patient had interactions with their amlodipine, their rosuvastatin, and their clopidogrel. And what we did was we made an entire plan and sent it back to the family physician and said, if this patient tests positive and we initiate Paxlovid, these are the 3 things we're going to do with their medication. What do you think of this? In Ontario, pharmacists have the ability and the authority to adapt prescriptions, which means I probably could have made those changes without authority, but I love collaborating with our local family physicians. And I feel it's really important to have very good high-level 2-way communication. So I sent it off saying, this is what I'd like to do. And I'd like your feedback because maybe I missed something. Maybe there's an indication that I didn't know about. My patient actually didn't know why he was still taking his clopidogrel. So it was really good to have that level of communication. The physician agreed. And we have a huge note on the patient's profile. When patient X calls in and has tested positive, these are the 4 things we're going to do. We're going to dispense the Paxlovid, and then we're going to adjust his meds in this way. Next slide, please. And then the last scenario that we've seen is the patient is COVID positive and they actually call the pharmacy, either because they don't have a family physician or just we're their touch point and they're used to calling us, or their family physician is working in Emerge that day and isn't able to take their call because you rural family physicians, you do everything, you really do. So this patient called us. He had tested positive at home on a rapid antigen test. We determined that he may benefit from using Paxlovid using the Ontario Science Table guidelines. We did a med review immediately for him. That way, once I was able to fax and then call the family physician in that same pieces of documents, I said, look, I think they would benefit from Paxlovid. This is the dose because I can check his renal function using Clinical Connect. And these are the meds that I think we should change at the same time. We also follow up each of these faxes with a direct phone call to the office because I know faxes are numerous, and especially when they say the meds check form right at the top, it might get put in the I can take a peek at this later file. So we follow up each fax with a phone call direct to, and if I can't track down the physicians through their offices, I might use their personal email or cell phone because they've given it to me and they're so kind in this area. So then the patient got the medication. Go to the next slide. So my big pearl is communication, considering adding ways for pharmacy to contact if needed. And it's time sensitive because we have 5 days, we do, but patients don't really call us on their first day. Consider you've got 2 options the way I see it. You've got as many options as you want, but the way I see it is 2 options. You can send the prescription to their regular pharmacy. They have their med list there. They know that patient and they can do the med review if you're confident in their ability to make those med management decisions. Or you can send the prescription to a trusted pharmacy to manage the med changes. It's a little bit more work because that's what we've been doing is for patients who aren't ours, but we can handle it. We've leveraged our different funding models to allow us to staff for it. And I'll call and get the med list. I'll call and talk to the patients, and then I will call through to the family physician's office. We can go to the next slide. And then this is actually the document that I referenced on my first slide. It's one of the University of Waterloo documents that I've been working on with Tara and a number of wonderful practitioners. This just came out yesterday. It's Paxlovid for a patient on a DOAC and the general recommendations that we have of how to manage that. As you all know, every situation is different. And if you can believe it, the patient, my first patient, my transient underhoused patient who had the DVT 2 weeks ago, we actually left their apixaban exactly as it was. And we added in a PPI with a hope and a prayer that nothing would happen, but we didn't want to leave him without any anticoagulant. We couldn't get him on the low molecular weight heparin. So this is a guide, not a god, and use it as you will, but we do find it really helpful. And my information will be included at some point, or maybe I'll throw it up in the chat. If anybody wants to send a consult my way, always happy to have that as well. Thank you.
Thanks so much, Kristen. You sound like a dream of a pharmacy to work with, I have to say. I think there have been, a few really great comments in the chat reacting to what you've said. I think Kate Miller said the, dispensing plan on hold, preemptive script plan is a fantastic idea. It's not the same as the pill in the pocket where the patient has it, which has much more inherent risk. So that's really a nice illustration what you did. I think just going back to Kim, I will also just say, Kim, lots of requests for your form. And so just to let people know, we will get that form from Kim and put that on the website. And then to both of you, I love this comment from Sid Feldman. I am just blown away by how time and time again, we hear about ordinary, i.e. extraordinary, family physicians and other health professionals organizing complex care systems wrapped around the patients in their communities. Well done. So both of you, I think, just illustrated how and the amazing work that you're doing here. There are a few specific questions for you guys in the Q&A, and just ask if you could go into that Q&A and answer those specific questions to you. I think that would be great. And I'm going to now turn it over to Zane, because I know that a lot of people are keen on hearing about where we're at with COVID, what's up with the new variants, and many more questions that we'll get to right after Zane's talk.
So thanks, everyone. Agreed. I think the first 2 talks really talk about patients under care in an incredible manner, and it's really inspiring to hear many communities stepping up to the challenges that COVID throws us minutes in terms of testing or any other thing. So I'm going to talk a few slides around the current COVID context and what's going on globally, as well as some stuff around testing, a little bit about real life efficacy of Paxlovid, which I think was a question already in the chat, and going from there. Next slide. So our best measure, obviously, of community activity, along with serial testing of healthcare workers, et cetera, just because of the community testing rates being low, is probably waste, which is declining across the province, a good sign. And I think, again, because of the summer protections, it's likely going to continue to decline over some time, recognizing that this wave did have a pressure that was similar to prior Omicron waves in terms of community activity. Next slide. Thankfully, ICU is not an issue during this wave. The baseline rate of around 150 to 200 cases and about 75 to 100 vents was there. And there wasn't a big surge as was seen before. The hospitalization piece was, more than I think other waves, especially wave. It was not as bad as wave 4. Sorry, it was worse than wave 4.
Zane, I'm just going to interrupt you. Sorry, you're cutting in and out. I'm not sure why. Sometimes it's clear, and then sometimes it's cutting out almost.
Okay.
As if
Maybe
you're...
I'm gonna just take off my headphones here and see if I can just talk to the computer. Is that better? Yeah.
Yeah, I think so. Let's hope. It could be your internet, so let's try. Let's just keep going and see. But thank you.
Keep going that way. Okay. So as we see with hospitalizations, they remain still high. A lot of this activity is mixed. So some of this is admitted with COVID. Some of this is nosocomial activity. Unfortunately, many hospitals across the region have had outbreaks. Some of them fairly significant for COVID transmission. And then obviously the set number of admissions for COVID, especially again in individuals where this may have been milder, but even the frail individuals where mild disease can still lead to a hospitalization at that point. Next slide. In terms of vaccinations, and I think we'll talk about vaccines a little bit towards the end, but the rate of vaccines has been fairly flat over the last month and a half. There was a little bit of bump that was related to fourth doses as well as childhood vaccination, but we're seeing declining rates of vaccines going forward to less than 25,000 doses a day being administered. Next slide. Just to kind of give a context of who's being hospitalized, because I think that is a question that's coming through. Again, these are hospitalized cases by symptom onset date. These are people with COVID that came to hospital. So again, it's not necessarily people that are hospitalized because of COVID. Unvaccinated individuals are relatively small in our community. This is just total cases. They still, from a per capita standpoint, are the overrepresented cases that come into healthcare. But from a sheer number standpoint, and again, this deals with base rate in the sense that more people are vaccinated, meaning that those breakthrough infections are likelier, from a sheer number standpoint in the vaccinated population to drive people to hospital as compared to unvaccinated, which is just a small percentage. So the number of cases will be small. However, as we talk about Paxlovid and kind of the reasoning for continuing along with it, even pushing it, and certainly there are people where, it probably is a bit of overkill, but we do have to recognize that healthcare utilization is both unvaccinated and fully vaccinated individuals to a degree. And so making sure that we make those links, making sure we identify those individuals is still really important for healthcare utilization moving forward. It's finding the right balance for the highest and lowest risk patients. But there is certainly a fully vaccinated healthcare utilization. It's small relative to the number of fully vaccinated people that have gotten COVID, but it still is a percentage of what's coming through in that sense. Next slide. I quickly want to talk about the new variants coming through. So BA3 really hasn't done a lot. There was some description in England. BA4 and BA5 are probably the ones that are on the radar in terms of what's next to come to Ontario. And I'll show you some of the data from South Africa. And then there are recombinant variants that are showing up. These are, recombinant events that have happened between Delta and Omicron, between BA1 and BA2. They're showing more local clusters, whereas BA4 and BA5 and BA2.12 are the three that are kind of showing themselves in kind of mass events through multiple countries looking at sequencing. I'll focus on BA4, BA5 though, because I think BA2.12 is really close to BA2 and really, most of the rules still apply. Next slide. So this is South Africa, as everyone knows, BA1, not necessarily the origin, but the first country that described a BA1 wave was South Africa. And so you can see South Africa is, just these waves and, the original strain of COVID, the beta strain of COVID, the Delta strain of COVID, and then, you saw the BA1 wave. Interestingly, BA2 did not do a lot in South Africa, and the question, it took over all samples very quickly, but from a healthcare utilization case standpoint, it was actually very, very small. So there was a lot of questions whether or not that was just because basically everyone got BA1 and that really, upped immunity as BA2 was coming through. But for whatever reason now, BA4 and BA5 are now on the rise in South Africa and really have dominated the landscape in terms of variants, which probably does mean this is likely as things progress locally, are what we would expect to see. Because of all these punishing waves of COVID, the immunity in the population is relatively high. I think after Omicron, the seroprevalence was something like 80%, and only 30% of the population had been vaccinated. So, really a lot of natural immunity in the population. And looking at BA4, BA5 right now in South Africa, it's suggestive that hospitalizations are kind of lagging behind cases even further than prior waves in that sense. It doesn't necessarily mean that there's going to be a complete lack of healthcare utilization, but they are seeing, for example, deaths not necessarily rising and healthcare utilization being lower than even their Omicron wave, which it was relatively low in the context of prior waves prior to that. So, there is a lot of discussion about more of this decoupling between cases and hospitalizations, which again, may or may not be applicable here, given that we have an older population in different clinical context. Next slide. And this is data from the SIGA lab in South Africa, looking at neutralization of BA1 versus BA4 and BA5. And so the top is people that had only had natural immunity to BA1 and neutralization of sera to BA4 and BA5, and using a cutoff of potential clinically effective neutralization. And so you can see that sera from BA1 in naturally immune people did a relatively poor job in neutralizing BA4 and BA5 sera with a significant reduction in neutralization. You can see vaccinated individuals still have fairly reasonable serum to BA1, BA4, and BA5. So, the bottom line here is in a population that's highly vaccinated, hopefully between the Omicron that's passed through and the BA1 that many people and BA2 that many people have acquired, it will likely have less effect, but in patients that are still vulnerable, immunocompromised, where they may not have as much of a serologic response, and in patients that have had natural immunity and probably have some reduction against severe disease from their natural immunity, it's no guarantee that they can't be reinfected. And in fact, they probably are going to be reinfected as things come through again in that sense. Next slide. There's a lot of questions about testing and rapid antigen testing, and a phenomenon that I think we're seeing in Omicron. The left is a diagram from the Ontario Science Table that looks at days from positive PCR tests from a small study that was done on about 30 individuals. And you can actually see the sensitivity of rapid tests really gets better as people are progressive into their illness, and their PCR is positive, but even on day 0 and day 1, the sensitivity of rapid testing is really low. And this is a little bit different than prior variants where rapid tests were often positive very quickly in the clinical course. Often people were symptomatic by the time the rapid test was positive. I know many of you and a lot of individuals have reached out and said, these rapid tests are turning positive day 5, day 6 in individuals and not day 1 or 2, despite them having symptoms and a clear exposure. And so, this is one of the theories, and again, nothing is borne out, but with a more immunologically primed population with the antibodies, essentially with recognition of the virus early, the symptoms of, viral clearance, so interferons and cytokines that are being released to clear are happening much earlier in the clinical illness. And so people are becoming symptomatic early with a very minimal amount of virus there. And then, as the virus gets through its reservoir and progresses, people become rapid test positive later in the course. So, again, that exposure to high viral loads to symptoms, which was kind of happening much later in an immunologically naive population,
is happening much earlier in an immunologically prime population. And this may, account for why rapid tests are negative very early, despite a high-risk symptomatic person being positive on PCR and negative on rapid tests. And so it's just, for counseling for patients, especially for things like Paxlovid, if you get calls about patients that say, I have symptoms, my rapid test was negative, you really have to, serially test. For high-risk patients, really, try to use PCR as much as you can as well if you don't have access or rapid recurrent testing is an option. And again, not use a single rapid test to rule out COVID, especially in a high-risk situation in that sense. Next slide. There's a few questions around Paxlovid efficacy in real-life populations, and I think there is a really big question of, obviously the many trials we've done for COVID-19 therapeutics they were largely launched in July to December of 2020, and so we have drugs that were used in unvaccinated populations being applied and pre-Omicron populations being applied to a post-Omicron and fully vaccinated population. And so, as Andrew, I think, had talked about in the science table guidelines at your last session, setting a cutoff for higher risk and trying to use that as a methodology to really capture who may benefit. I will mention there is data being collected, not from us. This is a trial that's ongoing in the UK, Panoramic, where they're open label trying to quantify reductions or real life efficacy of these drugs in a vaccinated and Omicron population. Panoramic just added Paxlovid about a month ago. They've been using Nirmatrelvir as well, which is a drug that's not approved in Canada to date. And so, I think they will probably be the ones to generate data for us in terms of what this means. As their research networks have been incredibly integrated throughout all of this. And so they really can do countrywide data analysis in terms of what the efficacy is of this drug in high risk populations and what are really considered high risk populations. So more data to come. And again, I think this is one thing to keep our eyes on in terms of a pivot in Paxlovid strategy based on some of the data that comes out of this study. I think the last I checked a couple nights ago, it was 25,000 patients that had already been enrolled. So well overpowered to what we could probably do locally in that sense. Next slide.
I'm going to just actually pause here and maybe stop slides and maybe just a few Q&A if that's okay. And then
for sure.
We'll go to Evischild, which is, I think, a whole other topic area. And I know we're going to talk about that, but I want to make sure I get to some people's questions. I know you answered a lot of them. And there's lots in the chat back and forth about the rapid antigen testing and PCR testing and the positivity, because I think people as experience echo, of course, what you described, Zane. Just a reminder, and I think David's put this reminder in the chat a couple of times, is that, of course, if someone's symptomatic and they're eligible potentially for Paxlovid testing and they test negative on an RAT, you need to get them a PCR. Hopefully that's available for you and your community, but the negative RAT, you can't just be obviously reassured by that, and they can get that PCR, they're eligible for it. So as David also reminded us, anyone eligible for potential Paxlovid treatment per the Ontario guideline or the Ontario rules, which are wider than the Ontario Science Table guidelines, they are actually eligible for PCR testing. So don't hesitate. And the PCR testing guidance, we have a slide on that later in the deck, but it is much more expansive than it was back in January. And do check out confusedaboutcovid.ca because we try and keep all those documents up to date around that.
Yeah, I posted the link in the chat, and you can find where your patients can get tested, but you also can see the expanded eligibility criteria for PCR.
So I'm going to get to a few questions for you, Zane. So the first one is from Meetha Vij, who says, please comment on the new variant-specific vaccines. Should we recommend dose 4 or wait for the newer vaccines in the fall? And I think other people have, Susan Melvin has a similar question. She has many healthy 60-year-olds asking my opinion about whether they should get the 4th dose or wait until the fall for a likely updated vaccine.
Yeah, it's a really good question. So breaking it down into two is, what is the efficacy of a fourth dose as compared to 3 doses? And so this is largely observational data that's come from Israel, a little bit of antibody-based data that's also come from the UK, where in higher risk populations, and Israel's cutoff was 60 for their fourth dose vaccine campaign that was done in, I think, September, October, November. They saw a reduction in death, although the absolute numbers are incredibly low in that trial. We're talking 9 versus 23 in that observational data set. Reduction in severe COVID-19 amongst higher risk individuals. Again, absolute numbers were low, but there was a relative benefit that was seen as compared to 3 doses. I think it was a 60 or 70% relative benefit. So, it really depends on the context, and NACI's guidance was, wait 6 months, but also consider what's going on locally. If there's a lot of disease transmission locally, then you might want to make sure that those higher risk populations have optimized immunity for the foreseeable future. So, if we get to a very calm situation in June, it might not be the end of the world to consider seeing what happens going into the fall. But if we're in, a very dicey situation that we've been in for the last couple of months, it may have been a better deal to make sure that they have optimized immunity such that, they see the virus as optimally as possible. They were the first ones to get their third doses as well. I will say Moderna has put out data around a bivalent vaccine. It's not actually an Omicron specific vaccine. It used the wild type as well as, I think, beta as the other bridge. That showed higher titers of antibodies to Omicron as compared to an original vaccine as a booster. There's not really clinical data that's come from this. This is a press release to date. They are going to take that forward to the FDA, I think, and the FDA is making a decision in June around what to do around fall boosters for individuals. But all to say, there may be something else coming down. And so there is maybe that decision making to say, is it worth it to get the next dose? I wouldn't suspect that people would be excluded if they got their dose now from getting the Omicron specific booster if they're considered high risk at the end. But certainly there may be some vaccine developments that change the way we fundamentally vaccinate coming down the pipeline towards the fall as compared to prior.
I'm not sure you can answer the second part of the question, but I'll ask it anyway. Would having a fourth dose now delay getting a booster in September or October?
Yeah, I don't know if I could answer that. I mean, I think NACI is really trying to push, a 4 to 6 month gap between those doses. But if you were, a high risk immunocompromised person, I suspect there would be much more benefit than harm in dropping in that 5th dose if it's much more immunogenic than a 4th dose of a booster. So I don't know what the answer will be. It depends on the clinical context, the trials, etc. But I would presume for the highest risk populations, they'll want to optimize immunity very quickly for them, considering that probably the most that are at risk for vaccine failure.
And then Tish Hannon says, patients with 3 and 4 vaccines are getting seriously ill with COVID. Is there any evidence that current vaccines are working on new variants? So you answered a little bit of that, but I wonder if you could just answer it a bit more directly too.
Yeah, look, the data from the United Kingdom is really showing that there is a wean for protection against symptomatic infection, even with third doses over 20 weeks. And so, and you may temporarily kind of increase and it decreases again with 4th doses in that sense. The bottom line is there are patients that are frail where a mild COVID illness is not going to be, even a breakthrough infection with a mild COVID illness, it's not going to be easy for them, especially are immunocompromised and are extreme elderly in that sense. And I think the pattern we've seen, at least in our hospitalizations, has really been those two patients with significant multiple medical issues who are already on the fringe medically, or immunocompromised patients where despite 4 doses, they don't have antibodies one way or another. And that leads into Evusheld a little bit, but also the need to really make sure those patients are captured with our therapeutics plans, just to make sure that they're given every layer of protection possible before they end up in hospital.
So if, just to summarize, our vaccines are not as, the ones that we have are not as good at preventing us from getting symptomatic COVID. They are good at getting third and fourth doses at preventing hospitalizations and serious illness. But even a mild infection, though, can be devastating for some older, frail adults.
And immunocompromised adults, yeah.
Yeah. And so I think you also answered this, but Alan Grill asked, if you get infected with BA1, can you get infected with BA4 and 5? And it sounded like the answer was yes, but just confirming that.
Yeah, absolutely. I mean, at least the lab data from single labs suggests that it's a potential. It's probably less of a potential if you've had your vaccines and BA1 or BA2. But if you're more just based on natural immunity, it's probably a higher potential risk than a fully vaccinated individual. That being said, again, when it hits larger populations, we'll have to see what it means clinically.
Yeah, and then there's just a couple of, and so then some questions about treatment. So Mel Borens asks, inhaled steroids for post-COVID cough, what's the advice? I mean,
budesonide has some data for COVID therapeutics and was recommended by the science table as part of the therapeutic options for people that were not eligible or lower risk. Is there some post-COVID reactive airway disease? Probably. I think I do a little bit of work with long COVID, especially people with pulmonary complications, and asthma is not, or reactive airways is not an uncommon finding in some of them. I think if again, it's part of the clinical assessment. If there is some suggestion of that, if there's a clinical wheeze, if there's suggestion of asthma-like symptoms, then for sure give it a try and see if it helps. But at the same time, it probably is the time to start looking for other respiratory conditions associated with the post-COVID syndrome and or pre-existing asthma that's just worsened after the COVID in that sense.
Thanks. So then there are some questions around Paxlovid. And so this is for any of our panelists, for Zane, for Kim, for Kristen. A-Song is asking, please comment on rebound symptoms following treatment with Paxlovid. I don't know which of our panelists wants to comment on that.
I can talk about what's being seen, and feel free for everyone on the call if they've seen it too. So this is a phenomenon that was actually described in the clinical trials when Pfizer looked back. About 2% of people in the clinical trial EPIC-HR had these rebound symptoms where their viral load came down, went up again, and people had a recurrence of symptoms. Interestingly, Pfizer also said this happened in the placebo group too at about 1 to 1.5%. So I don't quite know what that means from the natural history standpoint. It is being described. There's a case report in the United States. There's a nice blog article from Paul Sachs in the New England Journal of Medicine. I've certainly seen a couple of cases where they're rapid antigen negative, rapid antigen positive, return of symptoms. What to do is the big $1 million question, and no one quite has a great sense. The Pfizer CEO says retreat them. I don't know if that's an evidence-based answer. If they're I think it's worth it to do the risk assessment of what's the implication. And I think the few patients we brought back for another treatment, and we've given them remdesivir, have been our major immunocompromised patients that get a rebound. So patients on rituximab or something along those lines, they get a rebound, where I'm very worried what the implications of that rebound are, and that patient kind of needs monitoring for them to clear. But if it's a 70-year-old who is borderline criteria, at the Ontario criteria at the lowest end, who gets a rebound, who is able to tolerate it relatively well, is it worth it to retreat? We don't have guidelines, and I don't think we'll get great guidelines moving forward. Although the U.S. is looking at this actively because they've done a lot of Paxlovid prescribing.
So a couple other questions about Paxlovid. Tamara Halling is asking, can you speak to how well people are tolerating Paxlovid, especially the more frail, fully vaccinated? I have been seeing most of my frail elders with mild COVID symptoms, but my one experience with Paxlovid has been quite a few side effects, weak, myalgias. Is this common? Kristen?
Attribute those side effects to Paxlovid or to the illness itself? Be my first question. And then the other thing is, so far, the patients that I've dispensed to, aside from the taste disturbances, has generally been okay. It's a really short course. It's generally been okay. And I always look at, might it also be the illness causing the issues, whatever they are at the time.
Yeah, great points. So Rhonda Wolanski says, when I have a patient who calls me with COVID and they're in the eligible group, I scramble to find their arrangements, etc., and then get them Paxlovid. But in the meantime, there are those many who don't call me, even though they're eligible for Paxlovid. When I talk to them after the fact, they've recovered well and have had mild illness. Are we overtreating with Paxlovid?
Probably. I think that's the elephant in the room. I mean, again, this is a bit of a game, right? Like it is hard to interpret data from a clinical trial that included unvaccinated high-risk individuals who didn't have Omicron in a world where there's Omicron vaccines and risk is not entirely the same, right? And again, studies like Panorama will probably help us figure out exactly what populations actually benefit. There's lots of holes in the Swiss cheese for people not getting Paxlovid, and we're seeing only, again, not really reflected, at least in our intensive care numbers, of people that get critically ill with COVID, despite all the holes in the Swiss cheese in that sense. So I think there is probably a bit of overtreatment, but at the same time, you never want to be on the other end of it and see that patient in the hospital to say, crap, like that was a treatable opportunity in that sense.
Thanks, Zane. Kim, I think you wanted to jump in too.
Well, I just think we've had conversations amongst our group, about this moral distress for physicians prescribing, both primary care and specialists. And I try to quell that distress. Like, we're doing the best with the information we have those informed conversations with your patients, talk about the limitations of the data, and do your best. And this panic that's come up, this swell of, oh gosh, am I missing someone? And it's Paxlovid and I'm going to save their life. They're not going to get as sick. I'm like, probably not that. So just really reinforcing that, have the conversations, do your best, follow up with the science table guidance and the OCFP summations and Tara's excellent handouts. And, we're all sort of on this ride together, and we don't know what we don't know, but just trying to quell that moral distress about you're missing someone, and have conversations with your patients. That seems to work okay.
Thanks, Kim.
I think the tight hold that was put on Paxlovid from the beginning also creates a bit of concern when prescribing and wondering if we're going to hit the right people. And it's been really categorized, in my view, in community, especially as like a Suboxone or a Mifegymizo that has all these tight restrictions, which means we were worried about access, and then access went crazy, and then maybe we're using it too much. But in reality, how many of our patients might be on hydrochlorothiazide or still on glyburide, and we haven't stressed about that? So I mean, I'm always balancing that risk versus harm. I think the goal is to get it to the people who would benefit from it the most, because remember, the people that were studied were the unvaccinated or undervaccinated people, and not necessarily those frail elderly people who had 3 or 4 or 5 doses already. So I think the potential for benefit is there, but it's okay to be cautious with it. The other comment I wanted to make is that I'm not sure that the undervaccinated population is always open to it, because they're already really hesitant to receive pharmaceutical intervention, i.e. the vaccine. So I think you're all doing an amazing job.
Thank you for those really wise perspectives. I think David also put in the chat, we have so far given 15,000 people Paxlovid in Ontario. And so thanks to all of you for your collective efforts on that. Olivia, I'm going to ask you to bring the slides back up where we paused at Evusheld, and why don't we go back to that? I will just say before we do that, one last piece is just, just a reminder that when we talked about it at our last session with Andrew Morris, we talked about the Ontario the Ontario Health kind of criteria, or the Ministry of Health criteria around who could get Paxlovid. So the eligibility, kind of almost like a screening piece. So these are people that would come through your door to have that discussion with you. But in general, you're going to be recommending Paxlovid to the people based on the Ontario Science Table guidelines. And so if you want to go over that again, go back to that session 3 weeks ago. And I think there was a really great discussion just about that tension between eligibility and the evidence-based recommendations. But I'm going to turn it over to you, Zane, to start us off on talking about Evusheld.
All right, thanks. And then I'll give it over to David here. So Evusheld, and I'm going to only try to butcher the name once. It's Teclistamab, that's the end of it, is a combination of two monoclonal antibodies to the RBD region of COVID-19. And so this is another one of those drugs that was trialed in a different population. This was given to patients prior to developing COVID-19 in a pre-vaccinated era. And so there was a large trial called PROVENT that was done that showed a reduction in symptomatic COVID-19, a small reduction in severe illness, although it was 0 versus 5 individuals. So, hard to extrapolate out from that, and 0 versus 2 deaths. But a marked reduction in symptomatic COVID-19 amongst individuals. This trial was done mainly in the alpha/original COVID era. And the only interesting thing about this trial is a lot of people ended up censoring their data after a certain point because they ended up getting vaccinated because they had to unblind them at one point during the trial for ethical reasons when vaccines were starting to come out. So, so again, this is one of these drugs where now it's come to the market, and what is the benefit in our populations? And I think, through Ontario Health, and David will talk a little bit about this, the consensus was really patients who make very poor responses to vaccines that would hopefully mimic those clinical trials in that sense, and really, high risk oncologic malignancies with a significant immunosuppressive component or immunosuppressive drugs, or solid organ transplants, which were chosen as the first two criteria as part of the rollout. And right now, ongoing a targeted rollout in cancer centers and transplant centers in order to incorporate patients. What the benefit is, hopefully will require, would minimize infections amongst those individuals that are high risk. If we rely on the original clinical trial data, and assuming these people make no responses to vaccines, there is efficacy against BA2. It's still not clear what happens with BA3, 4, and 5. So that may be something that changes and is particularly important considering that's probably what's coming down the pipeline, not BA2. And then, there may be a benefit against infection and severe complications. Again, the trials were not powered to really look at this. So, hoping that having antibodies on board would attenuate the course, hopefully, for individuals. These are given intramuscularly. They're given individually in the buttocks, or it's recommended. So, practically, we've had to give it in a private room as compared to prior immunizations where you can kind of just do it out in public. The wait time from the Ontario Health guidelines is 15 minutes after. So really a quick in and out, similar to a vaccine for most of the practical administration. I'm going to flip it over to David though, because I think he's going to cover the next part.
Thanks, Zane. Yeah, so this is something very different than with other therapeutics. The science table, as many of you know, has declined, partly because I think they're just too tired and needed a break, but had declined to opine on Evusheld. And so this was a very different process for us at Ontario Health to decide how to roll this out. We did pull together an expert panel very quickly to put this information together. And it involved a number of treating physicians from those groups that Zane has already spoken about. So there's been two pieces of guidance that have been published this week. The first is this information for Evusheld. It's a reference for providers who may be prescribing it. I'm posting it here and we're sharing it not because we expect family doctors to prescribe it. This is going to be prescribed and administered, in centers that see these patients on an ongoing basis. So this is not work that, we as family doctors or nurse practitioners are expected to do. But we did think it was really important to share the information because, as we know, our patients may very well call us to get our opinion, and we want to make sure that primary care clinicians are well understand it. So I'll post a link to this information in the chat as soon as I finish chatting. And if you go to the next slide, the other piece of information that so this is the current Evusheld eligibility. I believe we have 11,000 doses that have either arrived or are en route. I believe the first two categories of patients make up those 11,000 doses. When we start adding other immunocompromised patients, I think the total gets up to about 60,000 patients that may meet criteria in Ontario. But for now, this is what we're going with. And the next slide is just a handout. So this is a patient handout that hopefully the patients will get if they're being offered Evusheld. Again, happy to have people put it in their EMR, be able to email it to patients. But also it's a really good, just a brief understanding even for us of, what the drug is about and how it works and who should get it. So I'll post a link to both those things in the chat.
So the next slide just has some of that information and the links, and so we'll post that up. But there is a patient handout that you can provide people, and there's that information for yourself. So I know some of you have asked some very specific questions around eligibility, and so you can click on these. Once we post the slides later today, you can click on this for more information. Next slide. I'm going to switch gears a little bit right now, and we're going to talk a little bit about more about boosters and vaccination in general. I think, the point of this slide is we've done an incredibly good job getting a large majority of the population to 2+, of course. And most of our patients who are 70 and over, 85% it looks like, or almost 90% are now vaccinated with 3 doses even, which is terrific. But we can see that 3-dose vaccine kind of in that yellow bar, that percentage of patients with 3 doses is really declines when we look at all the age groups. And then what we see for the 5 to 11 is that there's still a large portion of 5 to 11-year-olds who don't have 2 doses of that vaccine. So only 36% of patients 5 to 11 have 2 doses of the vaccine. So there's still more room for us to support our patients to get the vaccines that would help them, particularly the 3rd doses. I know there's lots of questions about 4th doses. And the 4th doses and even 5th are particularly important for those who are immunocompromised or frail or elderly. And a reminder that Isaac Bogosh did a good talk on that about 5 weeks ago. Next slide. So just this is a webinar that is coming up that you could refer your patients to. It's given by the Vax Clinic and Scarborough Health Network, but I believe patients anywhere could join. Next slide. I also just wanted to flag for folks that we have summarized some of the confusing information about boosters in our Confused About COVID series. So there's a specific resource in our series about boosters. I think that what's been tricky is that the NACI guidelines don't jive with the eligibility guidelines in Ontario. So the eligibility guidelines in Ontario are much broader than actually the NACI recommendations. And so we've tried to kind of tease that apart a little bit in this resource. I think also we've tried to really be clear that there are some people where you really, you should be trying to get the 3 doses in adults, in all adults. And 4th doses in adults 80+, and those in congregate settings and those with weakened immune systems are really important as well. Next slide. But we have these good tables that you can take a look at. In the black is everything that where it really aligns with the NACI recommendations and eligibility. And in the blue is where, the eligibility is there, but there is some grayness with the NACI recommendations that you might want to review and have a shared discussion with your patients about. And so we have a separate table for those who have no weakened immune system, which is this table. And then the next slide you'll see is a table for people who have a weakened immune system. So take a look at these resources if you're confused about what boosters your patients are eligible for. I will ask now, Zane, Harvey Blankenstein did ask an important question that many people are wondering about. Can you update us on the status of vaccines for kids under 5?
Yeah, absolutely. So both Pfizer and Moderna have ongoing clinical trials. Moderna did have a positive result in their clinical trial with 2 doses of a Moderna vaccine in those under the age of 5. And that data, I think, was just published in the New England Journal a couple of days ago for anyone who wants to read through it. The surrogate endpoint is a little bit different. It's really using this immunologic bridge. So kind of what is the immunology of an effective vaccine in a 5 to 11-year-old or an adolescent, and then applying that into the same measures for children, considering that hospitalization, severe disease is probably not going to be, you're going to do a 200, 500,000 clinical trial to really see that benefit in that sense. So Moderna has applied for Health Canada as well as FDA authorization. There was a little bit of controversy in the United States around the FDA waiting for Pfizer to apply as well. And then because Pfizer's data for 2 doses unfortunately did not show that immunologic bridging endpoint, at least not in the full group, they were not invited to apply at this point. And so right now, Moderna is in the process of application. The Pfizer data for 3rd dose should hopefully be coming out in the foreseeable future. And again, probably will be brought to the FDA and Health Canada at that point. But, how long it takes, if more data is needed, et cetera, is going to be an interesting question. And so we probably aren't going to necessarily see what the outcome here is, at least until June or later. And I think that's when the FDA is starting to meet around this as well.
Thanks so much, Zane. So I know we're almost at time, and there's maybe a couple more questions that I might ask you before we wrap up. And I will also just say to the rest of our audience that we will talk more about the vaccine for under 5s at our next community of practice session, which will be in 2 weeks. So expect more at that time. As Alan Grill mentioned, Health Canada is, of course, reviewing this as we speak. So a question for you, Zane. So one is just about testing, and the other one is about, and then the other one is for anyone who wants to discuss about Paxlovid. But Esther Libman says, if a patient has COVID symptoms and tests negative, how many days should we continue to test before we give up that they don't have COVID?
Yeah, it's a good question. I mean, that science table guidance really does suggest by about day 4 of symptoms, the sensitivity of serial testing, like doing it every day for 4 days, 5 days is probably enough. The other issue is that we have other respiratory infections that are starting to resurge in the community. And so, is it that you had COVID and you just can't get a positive test that's done correctly? And remember, correctly is both oral and nasal. So as highly sensitive as you can get. Is it operator error that people aren't doing the rapid test correctly? Or is it another virus? And that probably could be a decent possibility going forward in that sense. But I think if you're getting to day 4 or 5 with multiple negative tests, then the likelihood is it's not COVID, outside of the scenario that there is a defined COVID case in the household or defined COVID exposure, where I think even then you probably have to use your pretest probability to treat it as relatively high if people become symptomatic elsewhere.
Thanks. And then I think Peter John asked a good question here. Last webinar, Dr. Morris said clinical trials don't establish safety. If so, how do we find a balance in our discussions with patients in trying to reassure them of the safety of COVID vaccines on the one hand, and caution regarding long-term safety and the need for ongoing monitoring?
Yeah, I mean, it's a great question. I mean, look, we have at least a huge wealth of experience with mRNA vaccines, right? The recognition that now we have a population that's aged a year with a full series of COVID vaccines now And, you know, a lot of them even 6 months after a booster without any major safety signals other than maybe myocarditis in younger individuals, does say to that testament that, you know, your long-term follow-up data is appearing in real time and has shown nothing in a long-term fashion in individuals in that context. It's tough. And, you know, again, people throw long-term a little bit more in a conspiratorial or more of a, that you know, this is all a, you know, big pharma, but you know, I think you can reassure, look, all Health Canada's resources are available. Ontario is very transparent about vaccine adverse events, and you know, that can be used as a document to walk through. And you know, the data really suggests that these vaccines are incredibly safe in most individuals, and the rate of side effects is very, very low.
Thanks, Zane. So I think we're going to wrap up. We're going to go to our next slide. We'll post this eligibility for PCR testing with our slides, so you can review them. Next slide. And next slide as well. David, you're just going to let people know, I guess, about this opportunity.
Yeah, absolutely. And people can, when they get this later today, they can reach out. So there's funding available for this fiscal year for any group of family physicians that's part or planning to be part of an Ontario health team to pay for online booking. So this is for people who don't yet have it in their office. You can put a proposal through your Ontario health team. It'll pay for the monthly costs for this. And I know a number of groups have also put in some project management support to help with implementation. So an excellent way to think about getting online booking set up for your practices and get some support for doing it.
Thanks, David. I recently got the chance to implement it in my own practice and really enjoy it. My patients enjoy it too. So hope you guys can take advantage of it. Next slide. I think we wanted to let you know that the abstracts are now open for Family Medicine Summit. The deadline is June 12th. So we'll remind you about that again at our next session. Next slide. And just wanted to, first of all, say shout out to all of the nurses on the call for Happy Nurses Week. You've been an incredible support and for our patients and for ourselves through COVID. I know I'm lucky to work with 3 amazing nurses on a daily basis, and in particular, I've been grateful for their work around COVID care at home during this difficult time. I wanted to thank all of our panelists for joining us today, imparting your incredible work that you've been doing in the community, along with your wisdom, and for taking the time to answer all of the detailed questions from our audience. So thank you for all you do. Thanks to my co-hosts, Liz Maga and David Kaplan, and then thanks to as well our back team who really help us to put on this show every time. And then thank you, all of you, for all of the work you continue to do and for joining us. We do send out an evaluation afterwards, and we always really take seriously your recommendations for what you want to hear next in terms of topics. As I mentioned, I think we're going to be talking about kids' vaccines under 5, but if there are other topics that you want to hear about, please let us know. The next session will be in 2 weeks. So until then, thanks to all of you for all you do, and we'll see you again in a couple weeks.